Well, good evening, everybody, and welcome to this webinar with Prof. Craig Barclay. For dentists around the UK, and certainly many dentists internationally as well, Prof. Craig Barclay needs absolutely no introduction. But for the sake of formality, it gives me great pleasure to welcome you here today, Craig, and to introduce you formally. So Craig qualified at the BDS from Glasgow in 1986. And took up his current NHS consultant post in Manchester in 2002. He's a consultant in restorative dentistry, an honorary professor in maxillofacial rehabilitation, an associate dental postgraduate dean for specialist training, and director of education for MANDEC, the Manchester Dental Education Centre. He's published over 50 refereed papers, written 3 books, and has lectured both nationally and internationally, and is head of on head and neck cancer and dental implantology. He's the clinical lead for Central Manchester in oral rehabilitation and oral oncology patients, and was one of the national assessors for the national cancer visits in 2009. He's chair of the national recruitment team for restorative dentistry run by Health Education in the Northwest. He's also director of education of Manchester Dental Education Centre and was a past president from 2009-2010 for the British Society of Prosthodontics, the BSSPD. Craig's been placing dental implants, placing and restoring for 30 years now. And he's been placing and restoring mini implants for about 15 years. So I can think of no better qualified authority on the matter than Craig. And it gives me great pleasure to welcome you here, Craig. Perhaps just before I hand over to you, this is one of these treatments or treatment modalities that's probably underutilized or, historically has been, I suppose at best dabbled with mixed results depending on case selection and ways of approaching these cases. And the research that you've done in the last 4 and 5 years has really narrowed things down and helped us to understand much better where this fits in and how this may benefit our patients moving forward. So thanks very much, Craig, and I'll hand over to you.
Okay, thank you very much, Steve. Thank you for the very kind words. Probably vastly overinflated in my opinion, but thank you for the invite. And thank you to Southern Implants for the opportunity to give this lecture this evening. Obviously, it's very difficult times for us all at the moment. In Manchester, we've just passed our peak of coronavirus, and I'm sure many of us watching this presentation know somebody affected. I know of a few people who have sadly passed away, and I currently know a few who are still in IT. So at this point in time, I'm sure all our thoughts are with these people. But Southern approached me because there's also time for us to do some educational events, and they asked me if I'd give this, and of course I was very delighted to be able to take this opportunity. So what I aim to try and do in the next 45 minutes is just talk about what the role of mini implants in your surgery could be. So I'm going to talk a little bit about how I developed and applied the new Southern mini implants, how I got there, and that was as a result of a randomized controlled trial we did comparing mini dental implants and conventional dental implants in the edentulous mandible. And I'll go through that in greater detail in a minute. Talking about what uses mini implants will have potentially for dentists out in primary care as well as secondary care. And talk about the potential benefits of the Southern mini implant as opposed to other mini implants that are out there on the marketplace. So if I start with some just basic overview, which I'm sure we all know, McGill, and it's quite frightening to think that this is 18 years ago, McGill consensus statements, Jocelyn Fine and her team stated that really the basic gold standard choice for somebody that's edentulous in the mandible particularly should have 2 implants and an implant retained denture. Interestingly, I've followed a lot of Jocelyn's work over there, and a lot of the cases they did in the early days were actually in class 4 mandibles. So mandibles had quite good bone, And we're going to talk a little bit later about more atrophic mandibles and more elderly patients, because even with some good class 4 ridges, it's quite straightforward sometimes to make reasonable dentures and not have to use implants. The Brits, as we normally do, came into the scene a bit later, and it was a few years later in 2009, but incredibly 11 years ago now, that the York Consensus Statement came out, where we again stated that we felt that in the dentulous mandible, 2 implants should be really the gold standard. But since 2009, I would like to say this probably hasn't become the case for most edentulous patients in the UK. So why do we think this is? There's a paper from a team including Janice Ellis, who looked at why patients didn't seek implants and what their thoughts and experiences were on it. And some patients think they're just too old. Some are too scared of the surgery. They think the surgery is quite involved, and they say, I'm too old to have anything too advanced. And for others, it's the cost. Clearly, implants are perceived as being a very expensive and involved process. So I want us to think a little bit about a problem I see quite commonly in our clinics, and I'm sure it's not just Manchester that sees this. Patients who've got very atrophic class 6 and 5 mandibles. These patients have real problems, even with the best prosthodontists in the country, of having decent dentures that they can wear and function with. If we go back many years, Professor Tallgren's work, when she looked at edentulous patients, we all know what happens. We know that the mandible is going to lose bone at 4 times the rate of the maxilla. But there's other things that happen when this bone loss occurs, which are quite important, and we'll come back to a little bit later in the lecture. We also know that if we put implants into the lower jaw, not only do we preserve bone around the actual implant bed itself, but by functioning the implants and the prostheses, we can actually gain bone posteriorly as well. And this paper by Paul Wright's team showed that very nicely, again, a long time ago, 18 years ago now. The other thing that hasn't hit the press and dental literature as much is what happens in very atrophic mandibles if you put implants in and you load them, because we have, I think, a number of us have all seen cases where mandibles fracture in such circumstances. And clearly that's not something that we want to be encouraging to happen. So I'm going to show you a few cases that I've seen in my clinical practice. So this was a case where a dentist had placed 2 implants. One, when they had placed it at primary stability, the one on the right wasn't very good. So they moved it slightly distally. When they reviewed it, there was a problem. And then when they reviewed it subsequently, they had to refer it into a max fac unit because the jaw had broken. The implant had to be removed and the mandible plated to restore function. This is a case actually that was treated in private practice for the upper arch, but the mandibular reconstruction was done at Manchester Dental Hospital many, many years ago. And you can see they had 4 old IMZ implants in the mandible with a fixed bridge on it. And if you follow the case, you can see that a few years later, instead of the mandible gaining bone posteriorly, she actually got a physiological fracture of the mandible on the right side. The MaxFac team weren't keen on trying to plate it for obvious reasons. It was undisplaced, so the superstructure was taken off. It was allowed to heal. A removable bar was made for the implants, and subsequently a denture was made. And as you can see in this radiograph, a few years later, the mandible had healed. So the question really is, how do we manage edentulous mandibles in the first case, but also very atrophic mandibles? Because clearly, if we drill big osteotomies into these mandibles, we weaken them and we create a possible stress line for fractures. So as many of you may know, I've been doing mini implants for some time, and they had a very bad press. They were getting used, probably in some circumstances inappropriately. And we wanted to compare mini implants in the mandible with conventional implants. And we were fortunate enough, myself and Sarah Jawad and Professor Tickle and his team, to receive funding from the NIHR to run a randomized control 2-year trial comparing mini implants and conventional implants. And many of you will have seen this problem where an elderly patient comes in, you look at their edentulous ridge, and the floor of the mouth is actually higher at rest than the ridge. And then you take a radiograph, and with the 5mm ball bearings in, you can see that the ridge anteriorly is not much more than 1 centimetre to 12 to 14 millimetres maximum. And we think, well, what can we do for this patient? And in fact, this patient was in their early 60s. And you think, well, this is going to be a problem for the rest of their life, and a significant problem. So as part of the trial, we called it the Simident trial. So it was conventional implants as opposed to mini implants. We needed to find out if we could recruit patients onto such a trial. Would they be prepared to try out a conventional implant against one that's maybe not such standardly used by the profession? Would the patients agree to take part? Would they stay in the trial? And could we measure various things from pain, anxiety, quality of life, satisfaction, chewing, and cost? And so I met, as you can see, back in March 2012 with a cohort of patients who had received implants, both conventional and minis, at Manchester prior to this period, and asked them what their opinion was of their conventional implants and of their mini implants, and whether, if they hadn't had implants, would they have been prepared to get involved in the trial. And what sort of questions did they feel I should be asking to try and answer some of the questions that I had about implants? The things that came out were quite interesting. A lot of the patients said, actually, until their dentist had told them about implants, they didn't really know much about them. Now, accepting that that was 8 years ago, I still thought there was a lot of stuff in the press about dental implants at that stage. A lot of patients didn't think they were suitable, many saying, well, I'm over 70 years of age now, I wouldn't be suitable for implants. A lot of patients thought that they hurt them, that putting implants in was quite a painful procedure. Obviously, elderly patients said they had medical and personal commitments that might not allow them to undertake quite a lengthy process. A lot of patients think the surgery is quite involved. A number, obviously, given the sort of cohort and the age involved, had bad dental experiences back in the sort of 40s, 50s and 60s. And a number obviously thought that implants were only available privately and that they would be very costly. So I'm not going to go through this slide in any great detail, but suffice to say, what happened was we asked general dental practitioners in the region to refer in patients who were having problems with their lower denture. They had to all be edentulous in the upper arch as well. We then discussed with the patients whether they would be interested in participating in a trial, explaining to them that they wouldn't be able to have the choice of which implants they ended up with. And then they discussed it with myself and Dr. Jawad, and we discussed that they would have to have new dentures made first, and then there would be 44 patients based on a power calculation that would be randomly allocated. There were a lot of other things that happened. The mini implant system we used was a 3M Imtech Mini, which was the most available mini implant that was really available at the time. And we used Astra implants, the TX implant for the conventional implant. And the process, as you can see, is the same for both following the placement. All surgery all the dentures were made by Dr. Jawad, and all the surgery was carried out by myself, and then the patients were rehabilitated on their implants. The conventional implants, they had conventional surgery, their Astras placed, the studs placed at primary placement. So it was a one-stage procedure with the studs, then sutured round with soft tissues, and then the implants were not loaded for 8 weeks. The dentures were left out for a week and then adjusted for the next 7 weeks prior to having the clips added. So many people didn't know what the differences between mini implants and conventional implants are. For it to be a mini implant, by definition, it has to be less than 2.5 millimeters in diameter. Most mini implants come in several lengths and are very similar lengths to conventional implants. The one difference, obviously, is they were one piece and not two piece. From a patient's point of view, the thing we had to explain to them was obviously the mini implants were done flapless, so there was no flap raised, no peeling back of the gum, as we said to the patient. There was a minimal drilling compared to conventional implants. So in theory, but we didn't know, there might be less pain. And obviously mini implants were significantly cheaper than conventional implants with a stud and the various components. The mini implant arm went through surgery as I described, and they had a tissue punch drilled, and then the Imtech Minis seated and torqued in place. And we got patients referred from the dentist. They had to have no natural dentition. They had to be reasonably medically well. They obviously never had to have any implants before. They had to have significant problems with their lower denture, and the bone in the lower jaw had to be a class 5 or 6. We didn't accept any class 4 ridges, so they had to be pretty atrophic ridges to be accepted in the trial. And here's the timeline. We started in October 2013. It's hard to believe it was 7 years ago now. And we completed recruitment 1 year and 1 month later. That was a timeline that was made that we had to start. So we had to recruit within a year. And the hope was to get 44 patients. And in fact, we had to actually recruit 45. And that was because we recruited somebody who then disappeared for 2 or 3 months abroad, but came back and insisted that we treat them. The group MI is the mini implant group and the CI is the conventional group. And you can see that the age range is very similar for both groups. There were more females than males that wanted to undertake the trial. Most had been edentulous for around 20 years or so. And most of them were pretty anxious, actually, about the procedure and the idea of having implants. This was quite an important graph from my point of view, because being the surgeon, if most of them had had considerable or severe pain during their operation, I clearly wasn't carrying out my role properly. But you can see that there was only a couple of patients that had mild or moderate pain during the procedure, that had conventional implants, and none with the mini implants. This graph, however, is much more important, and this is a week later. We did ask them the day later, and we've got a graph of that as well, but the majority of patients who had mini implants had virtually no pain by the end of week 1. However, nearly 50% of the conventional implant patients at week 1 were still taking pain relief of some form. And if you look at the pain differences, you can see that there's quite clearly a marked difference between the mini implant group and the conventional group, and this was clearly statistically significant as well. Again, if you look at the dose and the amount of painkillers used, you can see that after a week there was virtually no painkillers being used by any of the mini patients. In fact, most patients who had mini implants said they only took 2 painkillers for the duration of the trial. But the conventional group, there was still 50% taking painkillers at a week. Quality of life was very interesting in that both groups improved significantly, and both groups were very similar, as you can see from the distribution graph there. The general satisfaction scores increased dramatically for both groups, and again were very comparable between the minis and the complete denture group. And in terms of comfort, which was slightly surprising to us, both groups improved dramatically as well. And really no statistically significant difference, although the conventional implant group was a little bit more variation in the short term. Ability to chew, again, this was somewhat surprising. There really was virtually no difference between the mini implant group and the conventional group, suggesting that those with mini implants could chew as effectively as those without. That was the patient's perception of chewing. We also assessed the chewing by doing what was called a gummy jelly test. I don't have time to go through all the results of everything, but it is published. The main obvious differences in terms of other things was the actual cost. You can see significant cost differences in just the hardware that it would cost. In terms of patient costs, that was time and transport and stuff. But basically, we surmised that it would cost at least 3 times to put conventional implants to those of mini implants just for hardware to patients. So significant cost differences between the two groups. So the conclusions from the trial, because we followed the patients up for a period of between a year and 18 months afterwards, but not long term, although we still see a number of the patients, was that the mini implant group resulted significantly in less post-operative pain. They're obviously a lot cheaper to place, and actually in terms of quality of life, comfort, chewing and things, they were similar to conventional implants. The big concern, of course, with mini implants is their longevity. And one of the issues was that patients wondered how long they were going to last compared to conventional implants. So we published this about a year and a half after completion, and that's the reference there if anyone wishes to look at the data. What was very interesting, at the time we were doing it, we found out that some colleagues in Brazil, the D'Souza group, were running virtually the same trial. And we weren't aware of it until we had just started our trial. They were funded and did a very similar trial, the only difference being they compared 4 mini implants to 2 mini implants to 2 conventionals. But the results were remarkably similar. They did follow survival data, not for long term, but their survival data shows clearly, again, the mini group was less and significantly less successful in terms of survival to conventional implants, which again is what most people would say was the case back that time, 5–10 years ago. So what lessons did we learn? Well, we learned that there were problems with the mini implant system we used, and we had 3 mini implants fail during the trial itself. A few more fail subsequently. And part of that was related to the actual implant that we used. The drill that you drilled with for the 3M implant was larger than the implant itself. You only drilled to 50% of depth. And therefore, when you were placing it, if you reached the lower cortex, there were problems placing it. The other big problem with the Imtex was the O-rings, which were the attachments within the dentures. There were massive problems with the O-rings and them coming out and getting lost, which historically was a problem that we had with O-rings with other implant systems. Problems with the conventional implants, we did have slight issues because we did a 1-stage. A couple of patients got overgrowth of the soft tissue over the stud, and one patient, maybe 2, had the studs coming loose before we actually reattached, but nothing.
Okay.
This is a patient's view of what they thought. I'll let them say.
Smashing, no problem at all. The only problem I've had is the rubbers kept coming out. It got to the stage that I was writing down in a book how many times they come out. I swallowed a couple. I've even come back and said to Craig, can I have some? And he said, well, you know, but at the end, he actually put adhesive on it and they've never had no trouble since. They've gone, not slack, but they've gone that I can take them out with my tongue instead of pulling them out. Yeah. But that doesn't bother me because I can still eat anything, apples, anything with them, which I could never, ever do.
And if you can tell me about your experiences taking part in an actual research trial, what's been your experience of the research part? No problem. The good thing about it was when they give me an appointment to come, I asked them to make it so I wasn't in the rush hour with the traffic, and that was a good thing. The telephone calls, if they said I'll ring you tomorrow at 3, it was 3 o'clock. And in the trials, everybody was smashing, no problem at all. Brilliant. Nothing. And would you advise anyone in your position to have the implants done? Yes, I would advise anybody to have these implants done and not to worry, but it's the unknown for anybody about it. But the mini implants, I'd say yes. The other implants, the one where they cut the gums, then I'd still have it done, but I'd sooner have the minis because you've not got the pain after it and the stitches and all that. Yeah. Thank you very much.
Bye-bye.
What was interesting is we actually interviewed virtually all the patients subsequently, and those that had the conventional implants and the conventional arm all said that if they had choice now, listening to those that had the minis, they would rather have had the minis, even accepting that a number of the patients with minis had lost one of the mini implants during this time. So that was a team that did the research, and thanks to all of them, a lot of work was done. After that, I looked at, we'd been using mini implants in Manchester for a while, so I went back and audited about 100 fixtures that I'd placed over the preceding sort of 8 to 10 years. And again, saw this recurring problem that after about 5 years, the survival of mini implants was only about 70 to 75%, which clearly isn't very good. And part of the reasoning when we did the homework on this was twofold, but mainly due to the fact that mini implants, because of the nature of them, were made of type 5 titanium, which is an alloy. So some thinking was done, and then I managed to get involved with Southern Implants and Graham Blackbeard, and Graham kindly came over to the UK, and we had a conversation, and I said, could we design a new implant? Could we make it of pure titanium? And he said, oh, we have type 4, we called worker titanium, so they had very strong titanium compared to some other titanium on the market. And could we design it with a collar that would give it increased strength and therefore make it, hopefully, in terms of longevity, better? So these were the initial drawings that we came up with. We changed the design of the neck. One of the issues was a lot of mini implants had either square or round necks, which was a problem for soft tissue adaptation, and also with regards to strength. We looked at the actual attachment itself, and the ball bearing on it is a 1.8 diameter ball bearing that mini Rhine attachments stick to. So we wanted something that was fairly straightforward to place and something fairly straightforward to actually restore as well, with really minimal componentry if possible. So Southern came up with this ILZ implant, which you can see here with the ball attachment in the top, the hexagonal collar, the body and the apex. Now, we have been placing these for just over 4.5 years now. We published the first paper about a year and a bit ago about the designing and the early results from it. And this is the paper that was published in the European Journal. What we've done with it is really pushed it to its limits. We've again kept its use mainly to class 5 and 6 ridges, but we did some early work on that as well, because as you can see from the Howell and Kaywood classification, once somebody becomes more atrophic in the mandible, not only have they lost the height and to some degree the width, but the angulation of the remaining mandible alters. And other things alter as well in terms of the lower face height, etc., and the proclination of the mandible. So with this in mind, we looked at a lot of lateral kefts that we had taken over the years for our implant patients. And as you can see, just looking at 2 in particular, the actual shape of the anterior mandible can vary quite markedly from what I call a triangular shape to a U-shaped mandible. And obviously the sort of issues of placing implants into such a shape would be quite tricky. The other issue is about the angulation of that residual ridge. So Rafif, who's currently my PhD student in Manchester, got the lovely job of pulling 153 lateral kefts. We got ethical approval, and she's scanned them all and traced them all to look at these angulation changes. And I'm not going to go through the research in detail. The paper is in press, but suffice to say that when we looked at the mandible, when you got to class 5 and 6 ridges, the mandible actually tilted lingually to about 12.5 degrees. So if you put an implant in straight, the ball bearing and the implant would be at an angle of 12 degrees, pushing lingually, and therefore encroaching in the prosthetic space. If you then looked at the maxilla, the maxillary angle was around 14 degrees, which we know from obviously the angle of the anterior maxilla to what would be the positioning of the upper incisors. So the other thing that then crossed our minds were that Southern implants obviously have great reputation in coaxial implants. So could we make a coaxial mini implant? And the answer was yes, and you're going to see that a little bit later on as well in the angulation that was done. So Rafif then went off and evaluated the strength of these, because obviously if we're going to make implants of a different titanium, i.e. not alloy as previously, we need to make sure they're strong enough. So she's tested 5 mini implants. She's tested the Imtech, the Saturno, the High-Tech, and the 2 Southern mini implants, the straight one and the coaxial one in the extreme right. And again, I'm not going to go through Rafif's PhD in detail because there's several parts to it. This is only a very small part, but she embedded all the mini implants into an orthoresin. This is a standard way that implants are tested. The reason orthoresin is because of the elastic modulus of it, and therefore no risk of viscoelastic deformation when you're loading the implants. We also looked at the literature to look at what the bite force might be expected to be on mini implants, and you can see from the literature ranging from 2010 to 2019, the values range from around 100 newtons up to 250, pushing 300 at maximum. But you'd be expecting a mini implant to at least be able to withstand certainly 150, 200, possibly 250 newtons. So when you look at the results of her test, if you look at the Southern implants, you can see that the top left graph, until they start to either bend or break, they get up well above 300 newtons. The same for the High-Tech implants, which are from an Israeli company. But if you then look at the Imtechs and the Saturnos are around 200, and the Imtechs start to bend or fracture under 200 newtons. And the coaxial one, again, is around the 300 Newton mark. So if I show you the actual figures and the averages, the one that is strongest by far is the straight Southern implant, which is about 330 Newtons. The High-Tech's Israeli one is about 300 Newtons, which is a type 5 alloyed implant. So the Southern pure titanium one is actually stronger than an alloy. The coaxial one comes in about 292 Newtons, and then the remaining 2 Saturno and Imtech are 220 and about 150 roughly. The other thing just to say, we were concerned, we had used 10mm implants for the last 2, and we were worried if length had any effect in this. So to double check that, we checked 10mm and 13mm conventional Southerns and other ones. And you can see in these 2 graphs that there was no difference really between the length of the implant and when it was going to break, because the implant would break just beneath the collar. And that's shown in these 2 tables. So as I say, we also developed this coaxial mini implant, which has got a 13-degree bend on it. There was 2 reasons for the 13. One is that by putting a 13-degree angle, the stud is still within the hexagonal collar. So therefore the insertion tool doesn't have to be any different, but also 13 degrees fits beautifully in with the mandibular angulation and also for maxillary angled ridges. So how retentive are these? This is the first patient, and you hopefully with me talking over it could still hear the click. The answer is very retentive, and in fact some patients struggle to get their lower dentures out in the 2 Southern mini implants. This lady had her implants placed 4 months, 3 years ago. You can see that she's fairly elderly, and in fact, when we chased her up for a review, sadly she's now in an old folks home, but we managed to get her in last month. She suffers quite badly from dementia now, but we took a clinical picture and a radiograph of her, and this is 4 years, 3 months down the line, and you can see that her implants are still probably as good as the day we put them in. The other interesting aside was her carer came with her and said that she was able to put the dentures in and out for this lady, no problem, and she could keep them clean, which is very important because you can see the soft tissue adaptation around the hexagonal collar is very nice and very easily cleaned. So obviously since 4.5 years ago, we've gone on and tried these out in various circumstances. We've put them into the maxilla. And we use a standard protocol. These are for retention, these aren't for support. And so therefore in the mandible, we put 2 in. We don't feel the need for 4. If you put 4 in, it's additional cost and no actual benefit. as particularly shown by the Brazilian trial. But in the maxilla, we put 4 in, but we do think it's very important to still provide palatal support. So we're not keen on putting horseshoe dentures over the 4 mini implants in the maxilla. This particular case had 4 coaxials on the maxilla and 2 straights in the mandible. So we do standard planning for this. We take a model, we mark the midline, we measure 13 mils either side, we create a base plate with 5mm ball bearings to take our radiographs. And the reason we use 13 mils either side is some work that George, very good friend who's back in Greece now, did some work with me in 2006. And Phil Smith and myself were looking at the distance between implants. Did it make any difference in terms of retention? And George found that the best distance was about 29 mils. The problem was that if you started using as wide as that, you were going around the curvature of the mandible. So really inter-canine distance of between 22, 23 and 26 mils is ideal. So just for those that haven't seen implants being done, I actually did a real-time video not long before the COVID shutdown. This is a patient we did not that long ago. From start to finish, the placements take about 10 minutes. So I didn't want to take 10 minutes to lecture up. I've cut it down, but it's got real-time times coming up on the screen to give you an idea. So we basically numb the patient up, use the stent to identify the place so we know we're nowhere near the mentals. Tissue punch, we use a 3mm one so the tissue is wider than the implant we're going to place. 2 reasons. We don't want to catch the soft tissue when we're drilling because the floor of mouth is fairly close. And secondly, we want the implant to be slightly smaller than the hole we've created in the soft tissue. You can see we use the precision drill and then the 2mm drill for placing into the mandible. So you can see in real time that the actual drilling in total takes only about 2 to 3 minutes maximum. So 2 drills to use, the precision drill and then the 2mm. And obviously in the current climate, you're wanting to do things as easily, simply, and creating as little aerosol as possible, without any, if ideally. And this is very, very simple. Probably most important procedure is this bit where you explore the osteotomy. Now, because the osteotomy is small, an endodontic probe is ideal. So we use an endoprobe to check it, flush out the osteotomy, and then hand torque in the mini implant. This happens to be a 10mm one. They currently come in 10, 11.5 and 13. I've said to Southern, probably 11.5 is of little use. We tend to either use 10 or 13. And we are looking at trying to create an 8mm straight one because there is the odd case that an 8mm would be very useful. Final torque, make sure they're level. Final torque, you can see that they get between 25 and 30 newtons quite commonly when placing these in. So they are very, very good in terms of primary stability. We leave them, in the trial, we left them 8 weeks before we loaded them. We now leave them 10 weeks, not for any reason apart from we've only had 6 failures, and all of these 6 failures occurred between week 1 and week 8. We've not had any failures subsequently. So my own view is that there's no point in loading them and they're going to fail within a week or 2. So we now retrofit, as we call it. We don't need an impression coping. You purely take an imprigum impression over the hexagonal collar and the stud. The lab analog locates very accurately into that, and then the lab can retrofit the housing and the clip within an hour. Or if you want to do it at chairside, you can clearly do it at chairside as well. So to finish off, I did say I'd try and keep it to 45 minutes to 50 max, so we're still on time. I'm going to show you some cases. As you probably heard from Steve, a lot of my work's cancer related. So some of these patients, we've pushed the boundaries with this implant and we've put them into a lot of cancer patients and some cancer patients who've been irradiated as well, just to see how these do as well as conventional patients. So this is Barbara. She had a very aggressive tumor of her anterior mandible. She was reconstructed by our oral maxillofacial colleagues with a fibula flap and a plate, as you can see, and then she had radiotherapy. And about 4 or 5 years later, she had significant problems with the soft tissue breakdown over the area, and her fibula started to necrose as well. So she now had a communication from the bottom right picture on your screen. She's had a communication from the floor of the mouth through to her chin. So she just basically dribbled saliva from her mouth down her neck, permanently. So the surgeons looked at the radiographs, realized that the fibula was no longer functioning, and digitally planned her to replace the fibula. And the decision was that we would use a scapula in this case. And you can see the planning of the scapula and how it's going to be placed, and the planning for the stent for harvesting the scapula as well. And this is Barbara 3-4 months after the surgery. She's got a new paddle of skin under her chin. You can see she's no longer a communication from her mouth to her chin. And she has now got a nice piece of bone from the angle to angle of her mandible. She then came in and said she would like to be able to wear some teeth, and not even the best prosthodontist in the building was going to be able to make this lady dentures. We talked about putting conventional implants in, but she was keener to have something that was as less invasive as possible. So we placed 4 mini implants into her maxilla and 4 mini implants into her scapula. We had some issues with the soft tissue around the lower mini implants, because obviously there was some skin in there, but with some help we got the soft tissue settled down, a bit of soft tissue surgery, and she had little mini dentures made, which not aesthetically that pleasing, but in terms of function were very good for her. We then went on to try them in other circumstances. This is a gentleman who's had a hemi-max, who's not had a flat repair, is only left with a tiny bit of residual ridge in the right side of his mouth, and just wants some teeth to be able to function with, and he's got some lower right teeth in his mandible. So we couldn't obviously make him any sort of conventional prosthesis in the upper that was going to be of any use. So in this case, sometimes we raise a small flap in the maxilla if there's not a lot of bone, just to make sure we're getting it in the bony window. Sutured it back with the 3 minis in place. And this is his half denture, as I call it, going in. And this gentleman came back delighted a couple of weeks later, saying that he could eat everything again, apples, steaks, the works. So, and he's now a couple of years down the line with no issues. So I'm just a week or 2 before the lockdown. I'm going to show you ones that didn't work. This was a gentleman who had one of the most atrophic maxillas I think we've ever seen. His ridge was only 2-3 mils wide in any area. Was not keen on grafting, and also was a cancer patient, so he'd been irradiated as well, so wasn't really keen on too much surgery. So we pushed the boat out to see if we could get some minis into this gentleman. As you can see from the surgery, I tried to get 4 in, the one on the left, in his upper left 4 region. You can see we've done a very peculiar angle, putting it through the buccal plate to see if we could get any retention there, and the primary stability was pretty good. And that was a post-op x-ray. Unfortunately, he's one of the patients that lost some of these. He lost his 2 outer implants, his 2 distal implants within 6 weeks, which is hardly surprising. If you look at the CBCT scans, you can see how little bone there was. The top left section shows the upper right 3 region, and you can see, in fact, that's less than 1.3 millimeters of bone in that area. While the centrals, which are still present, are within sort of 3 or 4 mils of bone, so a lot more bone in that area. So he lost his 2 outer ones. We made him a denture to clip onto his 2 middle ones, and they are still functioning, and he's very happy. One last case to show just before we finish, and this was another cancer patient who had been irradiated, and we needed to place a bone graft in, and we didn't want to load either the implants or the bone graft after surgery. So when we placed the southern, there's 4 coaxial southerns and 4 nasal implants, southern implants in. The 2 distal ones, I placed 2 mini implants in his palate. Mr. Maranzano, my max-fac surgeon, did all the implant placements, and we restored this lady with a denture that clipped onto the 2 mini implants in the intervening period. Ironically, this patient is actually South African by birth, and she was very impressed that the implants being used on her were South African. It was explained to her that the 2 mini implants were only there while the others integrated and the grafts took. And then we went back about 4 months later and removed the mini implants. We basically reverse topped them out. We weren't sure how easily they would come out, and there was a good crack when both came out. And when they came out, you can still see there were remnants of bone on both of them. She had a temporary screw retained bridge on the left, which was screwed in, and she's delighted with that, such that in fact she's not yet come back for the definitive one. She's had that in for nearly over a year now. So what's the success rate of the new southern mini implants? These are only the ones that have been placed at Manchester Dental Hospital, and they have all been placed by me. There's a few clinicians who have started to place them, but their numbers aren't included in this graph. I've placed 104 to date. We've had 6 that have failed, 2 I've shown you in the maxilla. The other 4 were all in the mandible, ironically. 3 of the patients basically lost 1, and they came back and said, could we put another one in? And we did, and their 2 implants are still there. The 4th patient lost 1, said she didn't want another one, and is still wearing her denture, just being retained in 1 mini implant on the left-hand side, ironically. So if we look at the Kaplan-Meier survival graph of the new ones, you can see a significant difference to the older mini implants. Obviously, we don't have long-term data on this, but certainly we haven't, touch wood, lost any implants post-loading to date. So this is quite important. So thank you for coming and listening. Manchester Dental School on the left, Manchester Royal Infirmary on the top right as you're looking at it, and the Christie's Proton unit, where we're doing a lot of new research with the Proton patients on the bottom there. So thank you for your attention. It's very difficult doing these webinars because we don't know how many of you have fallen asleep at this stage. But just before I open it to questions, just to say that we have run 1 hands-on clinical training day in Manchester that we had half a dozen dentists on. But the plan is to run some clinical hands-on training days using the Mini. And if you're interested in more information regarding the implant or courses, please contact in the email address at the bottom. So I'm now going to open it up for any questions. So I'm hoping that Liesl and Steve are going to help me out with the technology. I see there's 2 questions I can see there. Okay, so Matthew's asked me the question, there's no need to splint the mini implants in the maxilla as long as there's full palatal coverage. I normally have reservations with unsplinted conventional implants, so I'm surprised not required for minis. So the answer to that is, you're quite right. I have a lot of reservations about mini implants in the maxilla as well. What we often do is we actually only need to use the precision drill, and we don't often have to use the 2mm drill, or certainly not to the length, to get good primary stability. We purely use them for retention. So there is a team that has used these mini implants and published on it, that did a horseshoe denture in the upper, and their success rate on the minis is not so good, because they're using the minis not only for retention but for stability. So to date, we've placed in excess of 30 implants in the maxilla. We use full upper denture retained with the Rhine clips, which are plastic and resilient. And to date, we haven't lost any. So yes, we're not splinting them, is the answer to Matthew's. Peter's question, after the surgery, the lower dentures hollowed out. Yes, so after the surgery, We often don't hollow out the denture on the day of the surgery because there's a danger that they'll start wearing the denture again. So we don't do that until the review 1 week later. At the review 1 week later, we hollow out the denture over the implant so they're not loading them in any way. Advise the patient soft diet and to wear the lower denture as little as possible. Mustn't wear their upper denture at night because they will grind in the lower implants, which is not a good idea. And then we get them back at 10 weeks. And the area that we've hollowed out, we then inject the imprigum into and take the impression. As I say, there's no impression cap. We just imprigum, seat the denture, get them to bite together, and then take the denture off and locate the lab analogues. Last question, what would the maximum insertion torque, oh no, there's quite a few more coming in now. What would the maximum insertion torque be? I think for minis, I mean, the strength of these Southerns is very impressive, but I wouldn't be wanting to torque them much over sort of 25, 30 newtons, to be honest. I know there's a lot of people that like really high insertion torques now for implants, but that's for immediate loading. And I'm not keen on the idea of immediate loading these yet. There's a lot of, I'm keen to develop for the sort of 70, 80 cohort, the edentulous patients, that this is a very successful technique with good outcomes. And I think the more you push the boat out, the more failures you're going to have. So I'm not keen on that idea at all. Somebody's saying, what would you charge per mini implant in private practice? So what we started doing, if a patient comes in with a decent set of dentures, we will use their current dentures, and our current charge is about £1,000 just to put the 2 minis in and put the clip in. And when you offer that to patients, they're often very delighted with that, because obviously to have 2 conventional implants with studs and things, your bill's going to be 3, 4, 5 times that. View of mixing minis with conventionals, wouldn't be keen on that. I would only use the minis so that you're not loading the conventionals if they're in bone grafting or whatever. You can't really link them. And the other problem is if you're using mini implants, we have got a few patients who've got an old mini implant and one of the newer ones, and the studs are slightly different. You still have some issues around rocking and things like that as well. So I'm not keen on mixing that really at all. Would I make a fixed bridge on a mini implant? The absolute categorical answer to that is no. These are not, you do see people using mini implants for single crowns and bridges, and that is not something I'd be keen to use these for, because these are not developed for that use. They were developed by Southern for the really group of patients that are elderly and want something that will see them through and they'll be able to use for the rest of their life. So no, wouldn't be keen on using them for fixed bridge work. What's the longest follow-up period? So the longest of the new Southern implants that we've got is that lady I showed you, which she's now 4 years and about 4 months. I have got a patient who's got high-tech implants in her mouth, and she's had them 14 years now. I placed them just over 14 years ago, and she's still got the original ones. So you can get some that last a very, very long time. So I would hope with the new mini implants, given that they're type 4 alloy, I would hope you're going to get the longevity that you get with conventional Southern implants. That would be my dream. The other thing I haven't mentioned, which is I would like to throw out there so that some of you can maybe come back and tell me, I've never seen peri-implantitis around the mini implant. When mini implants fail, they just become mobile and exfoliate normally within a day or two of a patient saying they noticed it became loose. I've never seen a crater peri-implantitis defect around a mini, and I've discussed it with several senior implant people around the globe, and they're not really sure why that is. But if any of you do see it, please let me know. Martin's asked me, if you perforate the lingual plate, what's your management plan? Right, one of the things I didn't discuss, and the video might have given a false sense of security, is the importance of getting your angulation of your lingual plate right. So either one of 2 ways I tend to do it. I didn't do it for the video because it would have got my fat fingers in the way. You either put a lingual retractor, an elevator or something in just to push the tongue out the way so you get the angulation. Or what I tend to do is actually put a finger down lingually to get an idea of the angulation of the lingual plate. And then I drill, and if you leave your finger there, you'll also feel the vibration of your drill if you're coming close to perforating. That is the importance of why you must explore your osteotomy. It's no different from minis to conventionals. You must make sure you haven't perforated either lingually or buccally. And more importantly, with minis, if you're doing it flapless, you may not actually be in bone. I have seen some mini implants, not done by ourselves, where they've actually just been put in soft tissue, because it's quite easy, if you've got a very sharp ridge, to drill down the buccal plate. So it is important you explore your osteotomy fully with the endodontic probe, and you make sure you're in. If you have perforated, you must raise a flap and make sure that you've not damaged any vessel. Otherwise, you could have an issue. Question from David: can you recommend the mini implants for immediate load when used in conjunction with conventional delayed loading implants? Would you automatically take these immediate load minis out or leave them? So David, that's exactly what we did in that maxillary case. So the 2 mini implants were placed and we loaded them immediately, because the concern clearly is that you're not wanting them to be there forever. So if they do either loosen or lose bone, then you're going to be removing them anyway. So yes, you can. The other team that have played around with these minis, they have loaded them almost immediately or very quickly. But as I say, their success rates are slightly lower, and they've used them more in the maxilla. So I think there possibly could be a role for loading them immediately in the mandible, because the primary stability is really good. But as I say, we're going slowly because we want to keep the success rates up with these. How often does the patient have to replace the Ryan 83 retention clips? So far from the cohort that we've used it on, the lady who's had them longest, she needed hers replaced after 3 and a bit years. So the Ryan clips, very easy to replace. Most laboratories can access them very easily, but I would expect 2 to 3 years out of them. Do you see cluster failures? We have. One of the patients who we got a failure in actually had conventional implants placed, which failed, had other mini implants placed, which failed, and we put 2 of the new ones in, and one failed, one didn't, and then, as I say, we put one back in. We don't always know what the predisposing factors are. Clearly there are some, but we don't know them all. Another question, do we have the osteotomy speed the same as conventional implants? The answer to that is yes. Drill between 1250 and 1500, and so that's great. Marty, thank you for a nice presentation, thank you. I've placed quite a few mandibular minis in my career. The co-axis would be a godsend, as I've often found the ball in the wrong position. Exactly right. The beauty is that with the co-axis, there's a little marker on the brown holder that you put them in by hand initially, and you can actually make one in the insertion torque tool as well, so that you know that the stud is pointing towards you in the mandible and obviously pointing away from you in the maxilla. So yes, the co-axes are an absolute godsend. From my experience, Phil's asked me a question. It's always good when one of your best mates asks you a very difficult question. From your experiences, do you think that the quality of bone is more important than the available bone volume? Clearly, we know that implant survival is related to quality of bone, but also we know that the amount of bone you're placing your implant in is also very, very important, because if you take too much bone away and leave thin buccal plate, you will get resorption. So we all know that if you've got a nicer quality of bone and quantity of bone around it, then yeah, you're going to get less problems. So again, if you're using a 2.4 millimeter diameter mini implant, and you've normally in these circumstances got 5, 6, 7 millimeters of width, then you've got a lot of bone circumferentially around your implant. So yeah, thanks for that question.
Great, thank you, Craig. There's one more question in the chat from Finley Basin. How do you manage patient expectation with regard to long-term survival rates?
Okay, so again, that's a great question and actually a very interesting answer. The majority of the patients on the mini trial that we did using the IMTEX, I knew, having used IMTEX for years, that the survival data at 3 and 5 years was only about sort of 60 to 70%. So I said to all the patients, look, you have to realize that a number of you will lose some of these implants in the next 3 to 5 years. A number of the patients said, not sure I'll be here in 3 to 5 years, because a number of them are very elderly. But the other thing that all of them said without exception, and all the patients say with the Southerns and the ones that have lost it, they're so simple to place and they're so cheap that if you lose one, they're quite happy to come back and have another one. And the lady that hasn't had the other one with the Southern, she's actually saying, well, I'm going to wait till the other one fails and then you can come back and you can put 2 in again, but the other one's working fine and holding my denture fine. So I think I've always played down that we say that there's benefits to conventionals because obviously we know the long-term survival data in them. We don't know that for minis, so your long-term survival may not be as good, but the benefits in terms of surgery time, particularly in this climate where patients want things, you know, they don't want long treatment options. They want to be in and out of surgery fairly quickly. They want simple things that aren't going to give them pain. Then I think all these things added together, if you say to the patient, that's the benefits, the disadvantage may be I can't promise you 5-10 year survival at the same as conventionals, but we do see patients with minis that last that long. If you're placing them in a 70-year-old and they're going to get 10-15 years out of it, they're going to be pretty happy, I'd have thought.
Great. Well, Craig, thank you very much. And thank you everybody else for joining us tonight. I think that's all the questions for the night, and good night.
Well, we've kept to the hour, nearly.
We have, well done.
Okay.